Good morning, everyone, and welcome to the Insight seminar, Insight APSAD seminar. And I'd like to also welcome everybody who's watching online too and watching the webinar. If you haven't watched a webinar before, you're able to submit questions which can be answered afterwards. Today, I'd first like to acknowledge the traditional owners of the land in which this event's taking place and pay respects to elders past, present and future. Today's seminar, I think, will be quite an interesting one. We have Associate Professor Amy Mullens from the University of Southern Queensland, who will be talking to us about some recent research on Chemsex in Queensland, a topic I think that has been maybe a bit neglected and we're all a bit starved for finding out more about, because there's a very high level of substance use in those populations. So without anything else to say, I'd like to welcome Amy.
Thank you very much for that introduction, and also for the invitation to come back to Biella and share some of the work that I've done that very much has both a clinical and research interface. And just like to mention that I was based here for about 10 years working in the sexual health and HIV service. So very, very good to be back. So I would also like to acknowledge the Aboriginal people whom this land belongs to and continues to belong to, and acknowledge elders past, present, and emerging. So I'd like to acknowledge that this set of slides was developed by Kirsty Dakin, a research assistant and project officer that has been working in my team for a number of years, and acknowledge the contributions of Dr. Eric Fine, Maddie Ray, Robert Muscolino, Gary Williams, and Shane Garvey from the Queensland AIDS Council. I would also like to acknowledge the participants, because if it wasn't for people from within affected communities being willing to share their lived experiences, we wouldn't be able to progress best practice and enhance our understanding about how we can best meet the needs of those communities. So this industry report is available online at the web address mentioned there if you Google it, and it's also under review with a peer-reviewed journal at the moment. So for those of you who aren't as familiar with research in the LGBTIQ space, this acronym refers to a whole bunch of different groups of people, including lesbian, gay, bisexual, trans, intersex, queer, and questioning. And we'll use the word trans to refer to someone who does not identify with the gender they were assigned at birth, and they may identify as transgender, or agender, multiple genders, or another gender identity. Cisgender is someone who does not identify with the gender assigned at birth, and undetectable viral load. So when copies of an HIV virus cannot be detected on a standard test. So where did this research in Queensland around substance use within the gay community start with? So it really started back at my days at Biella in about end of 2002, when I was working with largely men who were becoming infected with HIV, and there was a lot of concern from the doctors and nurses from within sexual health, as well as also from mental health and alcohol and drug services, to understand what might be happening for men that may increase the risk of HIV transmission for some members of the gay community, but not others. So who was more susceptible, and which drugs were particularly implicated, to try to understand how we could better support the needs of individuals in the community from the perspective of prevention, health promotion, screening, and interventions. So this body of work formally started in 2004 through a PhD that I completed at QUT in partnership with QUAC and Queensland Health, and trying to look at those very same research questions. A few years later, several years later, I was approached by Queensland Positive people in the HIV Foundation Queensland that invited me to present some of those findings at a forum that was organized by members from the gay community to happen in conjunction with the launch of a documentary from the UK called Chemsex. And this was probably in about 2016, and so there was huge concern coming from within that community and communities, voicing concern about seeing their friends and loved ones become more affected by substance use, and in particular amphetamines. And there was a groundswell of concern of what can we do, what are the trends here, how do things go from occasional sort of party use to the slippery slope of it impacting life and functioning in more chronic ways. And so that event and discussion gave rise to then what is our current understanding of chemsex use in Queensland, and how can we document the current patterns to be able to then better inform health promotion and prevention programs. So this is what then led to our large quantitative survey. So the reasons for drug use within the gay community, or in the MSM, men who have sex with men community, that can include gay men, bisexual men, and other men who have sex with men that may not identify as gay or bisexual. So there's a lot of reasons that are similar to that of the general population. So to reduce tension, and for social facilitation, and for trying to escape from the pressures and stresses. Although there are also unique and perhaps heightened reasons for substance use in these communities, because there are additional stressors at times in terms of discrimination and victimization and things that may disproportionately occur for some members of this community. Also, the ways in which drug use has been historically linked with the gay community has predominantly been through social and sexual contexts, where members of the gay community have felt comfortable and accepted to socialize with peers. So what we know is there is a complex interplay between drug use within the gay community, and it's linked to sexual activity in terms of things like intimacy, sexual fulfillment, a sense of connection, which can be enhanced through substance use. And there are also multiple marginalizations or stigma that can go with members of this group depending on their life experiences. So, for example, if someone has been rejected by family and friends in their adolescent years in coming out, and then may have become infected with HIV and further felt stigmatized or had internalized negative beliefs about that health condition, that may further predispose that person to using substances as a means to cope and escape. We've also seen in more recent times the emergence of hookup apps, and this has dramatically increased people's availability for not only sexual partners but also drugs and the use in combination. So with increased accessibility to substances in Queensland and geo-networking apps, and I suppose the context of what may be considered normative in some aspects of the gay community, we have seen a huge rise in chemsex use in sexualized contexts over the last decade. So some of the other reasons that drug use may be used, and I should mention too that it's often the sophisticated use of substances in combination to have desired effects. So such as amphetamines with Viagra to allow for prolonged sexual contact over a large number of hours and sexual sessions over days, sometimes in group contexts, that allow for that to be more feasible. So Chemsex is related to more intense and adventurous sex than without drugs, and to increase that sense of connection and closeness. It can also reduce perceived, vulnerabilities having to do with HIV status, rejection, sexual orientation, internalized homophobia, and help to facilitate the connection. So in relation to then what we did more recently in partnership with QUAC was to roll out a large cross-sectional quantitative survey, and we received an overwhelming number of responses in only about a 3-month period, and this data was collected a couple of years ago, where we were specifically wanting to hear from men about their experiences with chemsex who were identified with the gay community, or MSM. So the recruitment strategy was in partnership with organizations within the LGBTIQ community, in particular QUAC, and we captured information about substance use, beliefs or expectancies associated with substance use, which was a large focus of the previous PhD program of research. So how can we identify what the perceived reinforcement or the desired outcomes or consequences are for an individual, to look at what their individual pattern of reasons for substance use and particular substance use. And in this larger program of research, we had developed expectancy measures specific for use within the gay community and the contexts and reasons for use, and 4 separate measures for stimulants, alcohol, cannabis, and amyl nitrates, which are also called poppers, and it's an inhalant that can be used to enhance sexual pleasure. So the stimulant and alcohol expectancy measures were incorporated because they're the most commonly used drugs of that type in chemsex, as well as looking at sexual practices and then sex and substance use in combination, and specifically in relation to chemsex sessions. So just a snapshot of who were our group of participants. So the majority identified as gay, with a very small percentage identifying as heterosexual or other, and then about a 1/5 or so of our sample identifying as bisexual. So we had respondents ranging from 18 to about 80, and a fairly normal distribution across age bands between the ages of 18 and about 60, and then smaller subsets of responses in the older age groups. So the majority of our participants indicated that they were not living with HIV, and we had about 10%, a bit less than 10% of our responses identifying as living with HIV, and then a large chunk, which I suppose a concerning subset, were unaware of their current HIV status, which has implications then for possible onward transmission and individual health outcomes. So of those who were living with HIV, the vast majority identified as having an undetectable viral load. So typically people that are highly adherent to an effective antiretroviral medication regime, which makes it not possible to detect the virus in their blood or for the virus to be transmitted to someone else. So in terms of the last HIV test, and I'll just point out that the guidelines vary depending on whether or not people are engaging in condomless anal sex or not. And if that's the case, more frequent testing is recommended, and I think it's around the 3-month mark. But other members of the gay community, it would be recommended, I think, 12 monthly. So with looking at these results, we have to be careful that we're not aware of what the individual sexual practices are of the people within the group, but the majority had a test within the last 6 months. And then we do have a smaller but still meaningful subset of people who have never tested, which is about 1/6 of the sample. So of the people who identified as not living with HIV, the majority had not heard of PrEP. So does anyone in the room know what PrEP is? Or those of you online, you can just think to yourself. So PrEP is essentially a course of HIV medication that is taken by HIV negative people as a form of biomedical prophylaxis for preventing acquisition of HIV if they were to be exposed to the virus. And it's something that's taken before and ongoing, sort of like a birth control pill, and it can be used continuously or on demand. And there's specific prescribing guidelines that doctors and sexual health nurses use depending on the individual patterns. And there's quite a bit of data that has come out on PrEP use, but the vast majority of data is indicating how effective it is as the latest strategy in HIV prevention. So that's an indication, at least when the data were collected, that even though PrEP exists and had come onto the PBS after our data was collected, there weren't as many people knowing about it as probably we would see now. And PrEP can be something then that can potentially mitigate sexual infection risks associated with chemsex. So I should mention one of the things we're hoping to do is repeat the survey in the post-PrEP on the PBS era to see what the trends look like from a harm reduction perspective and uptake. So we have also, in the last few years, noticed a rise in certain STIs, so in particular gonorrhea and syphilis in some subsets and regions throughout Queensland, and some of the sexually transmissible infections are becoming increasingly drug resistant. So we're also interested to know the frequency of STI testing, or of STI acquisition. And so there were a subset of people who had acquired 1 or 2 STIs in the last 12 months, but the majority of participants had not. And then of those who had been diagnosed or reported to have STIs, chlamydia and gonorrhea were most frequently reported. So now then, in terms of the snapshot of people engaging in chemsex, and it was defined with a fairly standard definition of prolonged sexual periods of activity in conjunction with substance use to gain desired effects in terms of social and sexual consequences. So of our subset of the respondents who had engaged in chemsex, the majority of those, or the largest percentage of people engaged in chemsex monthly, with smaller subsets weekly or fortnightly, and then a chunk of people annually, or sort of about once a year. So from that chemsex documentary and associated forum, the concern was that they were seeing their friends start to dabble with chemsex, or in particular amphetamines, or in combination with other substances, every once in a while, and then it started to become more of a frequent occurrence and start to impact on health, friendships, being able to attend work and function in other parts of their life. So again, we don't know what the individual trends or trajectories would look like, but it is interesting to note that a subset of the group would be engaging in chemsex on a weekly basis. So we also ran some additional secondary analyses, and we found that of MSM who we deemed at highest risk, so those were people who were HIV negative and not on PrEP, or who were living with HIV and had a detectable viral load. Approximately 13% of people in this group had engaged in condomless anal intercourse with partners of unknown or serodiscordant HIV status when drunk or high. However, 13% may be an underestimate of potential risk, given that 35% of the sample had reported that their last HIV test was more than 12 months ago. Nearly 20% of participants reporting having acquired an STI in the last 12 months, and over 1/3 reported having engaged in chemsex in the last 12 months, with the substances most commonly used typically in some variant of combination during chemsex sessions included amyl nitrate or the poppers, alcohol, crystal meth, and Viagra. So we've just done some additional analyses looking at condomless anal intercourse while under the influence with mixed status or unknown status partner. And when we say mixed status or serodiscordant, it's referring to one person living with HIV and the other person being not living with HIV. So of the people who endorsed this, we just have some comparisons of whether or not they engaged in condomless anal sex when they were drunk or high or just any time. And so we have between 25 and 31% of the sample. And then if we exclude those with an undetectable viral load or on PrEP, it's between 20 and 25%. So here are the patterns also of drug and alcohol overall use in this sample. And so we have, as we might expect, alcohol being most frequently used overall, followed by amyl, then marijuana, then Viagra, ecstasy, crystal meth, and then other amphetamines, etc. So cocaine use was lower in this sample than we've seen in other studies, and also mention of GHB, ketamine, steroids, and heroin. And the color bands then refer to the frequency of use for that subset for each drug class, with most frequent every day in the red, 2 to 3 times a week in the yellow, and once a week in the green, and the purple once a month. So it just gives you a sense of what some of the trends are in this group. So we also included some additional frequency information, so just depicted in a slightly different way. So if you're seeing clients who are from the MSM community or identify as gay or bisexual or have sex with other men, these are important areas to be screening for. So are they engaging in any chemsex practices? What sorts of substances are they using, either alone or in combination during these sessions? And also looking at how their course of use has changed over time. So what is their particular trajectory, and is it causing them or significant others in their life concern, or is it impacting on their functioning across one or more domains over time? Would be things to, I think, screen for and discuss with the clients that you're working with. So what we know is that there are complex links between drug use, so crystal meth in particular, and sexual activity among gay and men who have sex with men. That does set this group apart, and it does require a more specialist response to prevention and treatment in this group. So in terms of harm reduction, I think trying to promote safer drug use and harm reduction through things like information, support, continuing to dispel myths, promoting other harm reduction strategies such as PrEP, condoms, needle exchange, emergency care, so to access post-exposure prophylaxis, which is HIV medication that can be acquired through emergency departments for people who have been exposed to or may have been exposed to the HIV virus in the previous 72 hours. I believe are still the current guidelines. And just the importance of looking then at how things like consent and safety are negotiated, particularly if one or both partners are affected by substances at the time, and really working in partnership with members of these communities to design programs that are going to be most effective and most appropriate and most relevant. So it's important to look at also the complex interplay between individual psychology and needs and social context and sexual health, well-being, and public health, and how all of these things relate to the experiences of members of this community. And to look at, I guess, continue to challenge and improve negativity towards members of the gay community from wider society, to reduce then that felt oppression and discrimination and stigma that can continue to impact some of these patterns. So it's important to work also with clients and the communities to look at expanding ways that people who identify as gay can meet sexual and social needs in ways that may not necessarily focus on sex or drugs or both, and to, I guess, work with the individual and their expectations and their needs. And some of this comes back to motivational interviewing and trying to understand what needs the person is meeting through their patterns of use, and where possible, develop alternatives or find safer ways to use, or just to highlight their own awareness of the patterns and the impacts. So it's also important for men to be able to, so gay men to access specific and gay-friendly drug and alcohol and sexual health services that where staff are competent and provide appropriate, culturally responsive care. And there's a variety of interventions that many of you are already doing, and trying to really improve the staff awareness about working effectively and sensitively with members of these groups. And some of the data I'll be presenting next highlight some of the attitudes and beliefs that alcohol and drug practitioners have been documented to hold, and how that might have flow-on effects to our work with clients in terms of rapport, engagement, continuing to attend, and ultimately treatment outcomes. So continuing LGBTIQ awareness training, but particularly with a Chemsex focus, will be important. And also looking at co-location of alcohol and drug service providers with existing organizations in places where men who have sex with men feel comfortable attending. And then to continue to research in this space to pilot and evaluate novel interventions for clinical interventions, health promotion, and screening across alcohol and drug, mental health, sexual health, and gay community contexts. So it's important to also keep in mind what the trends are in relation to STIs, to help to promote awareness about PrEP and PEP, and the effectiveness, particularly now that PrEP is on the PBS. And ultimately, we hope that these data will help to inform services like the Queensland AIDS Council and organizations nationally and internationally through this larger program of research to develop relevant harm reduction programs, and also form as pilot data to apply for larger funding to allow more of this work to continue in terms of a participatory action research where clinical interventions can be rigorously evaluated to then help us to inform and shape our latest understanding of effective best practice. So this study has produced insights into a behavior that has only more recently gained public attention, in particular the use of crystal meth as a sex-enhancing drug, which is increasingly common. It also provides recent data on more long-standing drug practices and how these patterns relate to members of our communities in Queensland. So I'd also like to highlight that we've recently published the findings from our stimulant expectancy questionnaire measure for men who have sex with men in the Health Promotion Journal of Australia. And this and the other 3 expectancy measures can be used in clinical settings to then help to identify what the particular needs or perceived reinforcement is for your clients in relation to the substances they most commonly use. So I'll just direct you to some additional resources on the ACON website, How Hard, Victorian AIDS Council on Turning Point, Queensland AIDS Council, local gay-friendly medical practices, and Stonewall Medical also runs a gay and lesbian alcohol and drug group. Gladstone Road, Central Brunswick. You can also potentially look for psychologists through the APS who have a particular interest in working with people in the gay community and substance use. The wonderful clinicians at Queensland Health and other NGOs such as Lives Lived Well and Drug Arm, and then other community organizations, Quinn and QNADA. And there's also a really good resource called Turning Tina, and it is developed specifically in relation to stimulants and people living with HIV. So the other thing I want to do is then, I guess we start thinking, so what, and what are our next steps here? So I think, where are the places where we can have influence in reducing harms or functional limitations associated with chemsex or alcohol and drug use within members of the gay community? And one of the areas to specifically look at would be staff attitudes, as well as staff training. And so this is a study that was done some time ago now. It was only fairly recently published, led by Joe DeBattista and Jane Fisher from Queensland Health and Biella, in partnership with Drug Arm, to try to get a snapshot within Queensland of staff attitudes regarding members of the LGBT community. So we know that members of the gay community are identified as a priority group due to a whole bunch of reasons, and it was really heartening to see that members of sexually and gender diverse communities were recognized as a priority group several years ago in the National Mental Health and Drug and Alcohol Strategy. So essentially, it's important to understand staff attitudes because this can impact on treatment outcomes and also clients' willingness to engage in services and continue attending, which is critical. So what we did is we surveyed staff at government service in Queensland and also in Queensland and New South Wales, a faith-based non-government organization. And the research was done in partnership between the 3 organizations using evidence-based tools from the research literature looking at attitudes, experience, knowledge, familiarity, demographics, and awareness of organizational policies and procedures. and it was approved by ethics at Queensland Health. So we had 65 respondents from the government service and 65 from the NGO, with a higher response rate from the NGOs. So our samples are, I suppose, generally similar, but the government employees tending to be older, more males, similar self-reported sexual orientation, and in terms of geographic area of residence, we had there were more people in the rural areas in the government service. So the majority of staff indicated that they're supportive of LGBT issues, and a small number reported negative reviews. The majority of respondents disagreed with quite adverse statements about members of the gay community, although less supportive views were expressed overall regarding transgender people compared to the other groups. So the majority reported to be comfortable working with gay, lesbian, bisexual, and transgender clients, although 3 to 10% reported that they did not feel comfortable. So the majority reported that clients should be completely accepted according to their own personal and religious beliefs. However, 6 to 9% of staff surveyed felt that the sexual behavior among LGBT clients should be condemned or were sinful or immoral. And then we also surveyed around knowledge and organizational policies relevant to LGBT health. And there was greater self-reported knowledge expressed by government staff compared to NGO staff across a number of areas. However, there was a fair bit of uncertainty around many topics. So in particular, bisexuality, legal issues, family issues, domestic partnership laws, and organizational matters such as gender identification options on intake forms, definition of family to include same-sex partners, policies regarding bullying, abuse, or inappropriate behavior, and access to discrimination policies regarding sexual orientation and gender identity. So hopefully some of these trends have changed over the last 5 years, and if we were to do this survey again, we may see further increased acceptance, although it is concerning that there's a small set of people that really do feel uncomfortable working in this space, and to what extent could that be enhanced or not enhanced through further training or supported supervision, for example. So just keep in mind that the data are based on self-report, and there can be self-selection bias in terms of who participates, the generally low response rate, and we don't know who the people are, what their beliefs represent of those who did not participate. So overall, there was support and familiarity around these topics. However, what do we do about either improving or supporting to improve the views of the people who do hold negative views, and to what extent might that impact or their engagement with the client and potentially treatment outcomes. And there also being a general lack of knowledge around a number of key organizational policies. So to be effective, treatment has to address sociocultural features that influence the onset, maintenance, and relapse, and the unique factors that contribute to these health disparities. So further things that could be done is evaluating staff training and outcomes, continued partnerships with community organizations working in this space, and alcohol and drug providers, and also to, I guess, look at how maybe these trends have changed over time and what we can do to continue to help staff and select staff and more effectively work with staff to reduce their level of concern or negative beliefs about effectively working with this client group. And I just wanted to give, I guess, one other drug and alcohol related snapshot that we've recently done that's relevant to this topic. So I work very closely with Queensland Positive people in some research that was funded by the HIV Foundation Queensland and later by the Sexual Health Research Fund within Queensland Health, to look at novel ways of screening for HIV in a mobile way through point-of-care testing using more advanced testing technology through GenExpert, and working with trained lay providers who identify as someone living with HIV or someone from the gay community to provide outreach HIV screening. So we've conducted 2 programs of research, one involving mobile testing in the Toowoomba region to look at how we could potentially screen people that may be reluctant to attend mainstream health services, and doing that via recruitment and health promotion on geo-social networking apps with the peer testers. And then a more recent study where we had peer testers located at a sex on premises venue in the Valley for a 12-month period, operating peer testing on Friday and Saturday night late night sex parties. And so part of what that research was trying to understand is, are we capturing a unique group of people who wouldn't test if these services were available? So not only did we find that there were much higher rates of HIV and STI diagnoses in that cohort compared to other groups and screening locations, but also there was a meaningful subset of people who were diagnosed with as positive for HIV or other STIs that said that they would not have received a test had this type of outreach service not existed. So it has very important public health implications and how we can effectively remove and reduce barriers to access, and doing it in an evidence-based way based on standard operating procedures and clinical oversight to try to reduce trends of new notifications and onward transmission of people who are unaware of their status, and also to improve potential health outcomes of those individuals. So I've included the reference to that pilot, and then, as I said, there's another Toowoomba study I haven't included. But our next paper is to be analyzing the qualitative data from both patrons and peer testers as part of that same study to look at substance use within the sex on premises sex party environments, and to look at people's experiences around types of drug use, impacts, and harm reduction strategies, to then work towards greater health promotion in environments where sexualized drug use is more common. So some of the next projects I hope to do more in the development, delivering, and evaluating of Chemsex training programs for health professionals, including alcohol and drug staff. Continue to pilot and use substance expectancy measures with alcohol and drug, mental health, and sexual health staff, and also at partner community sites within the gay community in terms of screening, interventions, and health promotion. We also have a building collaboration with the University of New South Wales to explore experiences with methamphetamine use in Queensland, and we plan to be hopefully rolling out recruitment for interviews statewide among people who use crystal meth, and also to then continue to develop interventions to improve adherence to PrEP and HIV medication, particularly among substance-using MSM, to continue to reduce harms that could be associated with chemsex. So like you to, I guess, cast your mind to thinking about how is this relevant to me and my work in the various areas of your professional life, whether you're clinicians, researchers, educators, or other roles. So how is this information particularly relevant to me? So what things might I look out for or be aware of or further upskill myself on? What can I do to better meet the needs of my clients who may be engaging in chemsex? What can I do to better support or upskill colleagues and peers in this space? How can we ensure our services and staff are providing best practice, client-centered, culturally responsive care with chemsex using clients? How can we ensure clients feel more safe to attend and disclose? How can we potentially better screen for problematic substance use in a range of contexts, including mental health, sexual health, and substance use? And then conversely, how can we better screen in relation to sexual activity in alcohol and drug and mental health contexts? And what are then our next steps as a clinical and research community regarding improving trends and reducing associated harms of substance use within these communities? So I've listed a range of publications and work that we've done in this space if you want to do more reading. And I've also included my contact details. So if anyone is interested in collaborating with me in future projects, in the training, clinical interventions, prevention, health promotion space, or you want to chat through some things, or I'm very, very happy to do that. So please send me an email